lot has changed in the CPG process at the Academy, and I'm excited about some of the new recommendations that are coming out from that. The original one focused primarily on diagnosis of PJI, and we wanted to incorporate diagnosis and prevention into the new CPG. And so that's probably the biggest change. The diagnosis of periprosthetic joint infections is still pretty difficult to make, and so I think that was pretty clear on the original CPG, and we found that to still be true. I guess what surprised me the most was as we looked at some of the prevention strategies, the evidence that's out there is still quite lacking. And so it's certainly an area that deserves more focused research. From a diagnosis perspective, I think the evidence that is out there still really encourages the clinician to take a multi-pronged attack on trying to make the diagnosis. And so that's a combination of blood tests and synovial fluid tests, things such as that. Some of the new biomarkers that are out there really show some promising evidence. But again, I think the diagnosis itself needs to be done in a methodical way. With prevention, there's a lot of things that we do to try to prevent infection, from identifying patient risk factors to some systems approaches that we all undertake within our healthcare system to try to mitigate the risk. And the reality is we don't really understand that very well. And so I would encourage surgeons to go back to their local area, partner with their healthcare stakeholders, and try to understand their data. And if there's things that they're doing well to decrease the risk for infection, then we need to partner with researchers to understand that data and publish it so that we can all improve from that. Periprosthetic joint infections in general, it's a horribly devastating event for the individual patient. It's also quite a burden on the healthcare system. And so we really wanted to look at some prevention recommendations for our clinicians.